Good morning, everyone. My name is Anne-Marie Kelly, and I am the Deputy Director at the Centre for Excellence in Rural Sexual Health. And on behalf of the team here today, I'd like to welcome you to our Working Towards Sustainability report launch as the first milestone of our Rural Services Development Project. This is many, many months in the making, so we are really excited and thrilled to be able to bring this to you today. So, before we start, I would like to take a moment to acknowledge the traditional custodians of the land in which we are all zooming in from today. And for me today, that is the lands of the Dja Dja Wurrung people. I would like to pay my respects to elders past, present, and emerging, and extend my respects to any Aboriginal people who may have joined us in the Zoom room today. So we have a great agenda today, and I would like to take a moment to welcome some of our fantastic speakers who have jumped on to support us with our launch. We'll be joined by Jill Buddy, the Director of Women's Health and Population Wellbeing from the Department of Health. We'll of course hear from Carly March, who is our Rural Services Development Coordinator here at CERSH. We've been joined by Joanne Zamprioni, who is Operations Manager at Gateway Health and oversees Clinic 35, and we are lucky enough to also be joined by one of our regional GPs of women's health, the clinical lead from Bendigo Community Health Services, Karishma Kaur. So thank you all for coming in today and supporting our launch. So what I would like to start with is some housekeeping. Today will be recorded for anyone who wants to follow up on any of the information or wasn't able to make it today. This will be available on the CERSH website. We do have the Q&A function live in the back end of this as well, which we'll be monitoring. We're hoping to allow some time at the end for some questions, but it is quite a packed agenda. The Working Towards Sustainability report is quite a detailed report. So if we do go into the question time, we will endeavour to get all the questions answered through a Word document and sent to everyone who provided their email via the attendance link. So with that, I would now like to hand over to Jill Buddy, who has joined us for some words from the Department of Health. Thank you, Jill.
Good morning, everyone, and good morning, Anne-Marie. Thank you all very much for the opportunity to be here today. I almost wasn't because I couldn't handle Zoom, but I'm on now, so it's all good. And apologies, I missed the first few minutes, but I'd also just like to acknowledge the lands, the traditional owners, and pay my respects to Aboriginal and Torres Strait people and their elders past and present, and to anybody on the call who is of Aboriginal or Torres Strait Islander descent. From the Department of Health, we're really excited to see this report, and thank you very much to the team at CERSH for providing this report. It looks like it's going to be fantastic as a handbook for people to be able to provide sexual and reproductive health services. As you're probably aware, the Department of Health has a women's health program, of which I'm the director, and we're really looking to improving outcomes for women, particularly by reducing disparity in rural communities. And as you're aware, we've increased the number of sexual and reproductive health hubs from the original 13 up to 20 now, and really trying to make sure that we've got a focus in areas of need. We realise we haven't hit the mark for everybody yet, but we're still working on that. The other things that the department are doing, we're very much trying to look at scholarships to support training. So we've got another round of scholarships that are just going out as we speak to services both in women's health clinics, in some sexual and reproductive health services, in a number of community health services where they offer women's health. So trying to support that training, recognising that it is very challenging to get staff and maintain staff in these areas. We're really conscious of the importance of working with community health services particularly, and trying to ensure that sustainability of the service to build with the communities in answer to the demand for these services across the state. One of the other things that we've just launched recently, which was on the 5th of Feb, was the virtual women's clinic, and that will be coming online very shortly. And that will be the opportunity for anybody across the state to be able to ring a number. It's being supported by each community services, but they will be able to ring and have an appointment with a nurse and then get referred on to either a GP as a telehealth appointment or potentially to specialist services within their area. So that's another way for women to actually access services. And one of the other things we've done is look at a mobile clinic. So we've partnered with Breast Screen Victoria, and we have a service that's going out looking at going to some of the more remote areas where there aren't services, and particularly we're really lucky to be able to piggyback, I guess, with the Breast Screen Victoria bus, who is well known in a number of areas, but we've been able to partner with some community health services in those areas to provide. We've got experienced nurse practitioner on board who's able to provide a number of different services to women in those areas. And at the moment, I think the bus is in Dalesford. It was in Edenhope the first couple of weeks of February. And we'll be moving on to another area soon. So at the department, really conscious that this work of embedding and making sustainable women's health, it's in Dalesford to the 28th. Thank you, Kate. But it's really important that we're making sure that we have sustainable healthcare for women across the state. And we're really committed to trying to do that as effectively as we can, recognising that a number of women, particularly in the regions, have to travel a long way to get services. We're constantly being told that, and we fully take that on board. So anything we can do to embed services in local communities, we're very happy to support. So again, my congratulations to the team, the Centre for Excellence in Rural and Sexual Health, in developing this report. And to me, it looks like a roadmap or a manual on how to make sure that we can have these services in community health. So congratulations, and really looking forward to this session. Thank you.
Thanks so much, Jill. A fantastic overview from the Department of Health. And I know we've been talking about it a lot, how exciting it is with all the announcements. And I know I don't just speak on behalf of myself, but I'm sure there's many in the room today that really do share a deep appreciation around the commitment, both from the state and federal government, towards improving women's health across Australia. It's just fantastic to see and very, very exciting. So thank you. So, rural and regional workforce, we know, navigate many, many challenges when it comes to trying to provide high quality, sustainable sexual reproductive health care. But I do want to take a moment today just to acknowledge the incredible strength, innovation, and resilience that we often get to witness through our role at CERSH, supporting across Victoria rural regional sexual health services. I was lucky enough to grow up in rural and regional Victoria and have been based here my whole life. So witnessed firsthand the positive impact of having health professionals embedded within these communities. What we know is often because intrinsically this workforce is community minded, they wear many, many hats. So whether that's volunteering on the sporting committee or at your local school, they are very busy people. But what we do know is this provides them with a genuine understanding of the cultural nuances and the local needs to provide this type of sensitive care in a really appropriate way that meets their community where they're at. What this also provides is some fantastic insights into creative solutions. And we see a lot of great examples, and I'll just take a moment to share one. Recently, I was speaking with one of our regional GPs who had recognised an ongoing challenge for young people within his practice in accessing emergency contraception due to financial barriers. Now, because of his embedded relationships within the community, he knew exactly who to engage with and pull upon to go, how can we create a local solution to meet this challenge? What that then resulted in was a coordinated response whereby they are now able to provide access to a number of subsidised emergency contraception for young people who simply just cannot afford it, which I think is just a fantastic illustration of people coming together to go, how can we support our local community together with the levers that we can pull? So just a really nice example. And again, we get to hear beautiful examples all the time, which makes us really proud, even though it's not necessarily us, but we just love seeing the passion and dedication to supporting local communities. As I've also highlighted on here, I do want to just emphasise, we know our rural workforce are real leaders and change agents, and we hope through our report we're able to support and ensure sustainability around this service and this fantastic care being provided for many, many years with that financial support and leveraging the MBS and different support models to really safeguard our rural sexual health workforce. So before I hand on, I will just do a quick what are CERSH up to for 2025. And as most people know, we really pride ourselves on the collaboration and partnerships with our stakeholders, which we will continue on for 2025 through our communities of practice and our localised sexual wellness action plans. We're also very excited that it is a conference year for us. So in June at our Shepparton campus on the 11th and 12th, we'll be hosting the biannual sexuality conference, which is a fantastic opportunity to bring partners and stakeholders together from these communities to share, network. People often come away very enthusiastic being able to talk with like-minded people throughout the sector. We'll also be continuing to build the evidence around our sexual health across clinical context subject, which we have delivered over the last 4 years as part of the University of Melbourne medical degree. And I think just something that we're super proud of as part of this is the ability to provide the students with hands-on experience, particularly with implant-on insertion and IUD procedures, ensuring that they not only have the knowledge and skills, but also confidence to be able to deliver this as soon as they graduate. So super proud that we're able to do that as part of pre-service training. Additionally to this, we'll continue our partnerships with our agencies such as VATCHO through the Aboriginal Health Services and Culture, Ethnicity and Health. One exciting project for us is really looking at the refugee health nurse program that's embedded in many of our regional and rural community health services to understand and learn more about how we can leverage that resource, particularly the way they lead and support our migrant and refugee communities to access safe and culturally appropriate sexual health. We will also continue to hopefully bring testing to lots more of our regional and rural locations through our STIX test vending machine, looking at more partner agencies and how we can really test that to figure out how viable it is as an option ongoing for rural regional communities to access STI testing when a workforce may not be available. And of course, our working towards sustainability report and the Rural Services Development Project. This is a big ticket item for us that we really do see a lot of merit in, and we'll be spending a lot of time working on over the next 12 months. And with that, I'll hand over to Carly to give you some insights more on the report and the project more broadly. So thank you. Handing over to you, Carly.
Fantastic. Thank you so much, Anne-Marie. Hi, everyone. I am so excited to be here to share with you the Working Towards Sustainability report that we've been working on for the last 12 months. Firstly, I wanted to thank the co-authors of the report, so Anne-Marie Kelly and Professor Jane Tomney, for their expertise and work to make this happen. I'd also like to acknowledge the people who offered their time to participate with the report, and some of you are online here today, so big shout outs. Without your contributions, we wouldn't have this resource to share with current and aspiring sexual and reproductive health providers. This has been a moving piece of work that was developed to overcome the challenges current sexual and reproductive health face in rural and regional Victoria. Most of you, if not all, are aware of these challenges as we face them daily within the tireless work that we do in this field. A few key challenges that really stand out. Community health organisations are currently relying on the mix of funding sources to support their SRH model and maintain a comprehensive, near sustainable service. Any changes to these funding streams present significant challenges and could jeopardise the viability of clinical services. In addition to this, community health practices that only bulk bill face further financial pressures. Many are left with no option but to charge fees for some services, but what we know is some people simply cannot afford this care if it is not bulk billed. Also, our workforce is gradually ageing, which has led us to shortages in SRH practitioners in some rural and regional areas. So the Rural Services Development Project was established to work with key SRH professionals and stakeholders to offer an overarching solution and together overcome these barriers. So to achieve this, the project has 3 components. Firstly, the development of the Working Towards Sustainability report. The second is establishing a rural and regional training pathway map to show the most affordable and accessible training opportunities to support clinicians in gaining competencies in SRH. And lastly, to develop a formal mentorship model to support interested and aspiring rural and regional healthcare providers to build confidence delivering SRH care. So in summary, the Rural Services Development Project takes a holistic approach to rural SRH sustainability. It wraps around to enhance SRH services, building a competent workforce and ensuring they are confident and job ready. Thanks, Emery. Great. So the first step of the project was to understand our current SRH landscape and investigate the service delivery models currently operating. CERSH met with most regional women's health funded hubs in addition to some other SRH services. The biggest highlight, of course, identified was the passion and dedication the SRH workforce share and the initiatives explored through their limited time and resources. However, the SRH workforce faces several challenges in maintaining affordable care while striving to remain sustainable. Dr. Karishma and Joanne will discuss their perspectives during their presentations a little bit later. However, I wanted to highlight a few things that were discovered in our scoping. So firstly, services experienced the financial barriers with establishing their model with costs of infrastructure and out-of-pocket training expenses. Rural and regional areas experience challenges with workforce availability, including recruitment, retention, even access to training. So, for example, those in Mildura must fly to Metro Melbourne to access any face-to-face clinical placements, which can be timely and costly, as you can imagine. Additionally, newly trained providers emphasise the need for more education on MBS, specifically around co-billing. And not necessarily a challenge, but a key observation was the broad range of service delivery models that exist, which is expected given the diverse environments and circumstances. So this tells us there is no one-size-fits-all solution. Thanks, Emery. Great. So to respond to the feedback from the consultations, CERSH develops the Working Towards Sustainability report. So we gathered information from healthcare providers, operation managers, and stakeholders to build a practice manager's guide to enhance our SRH model. The report includes many considerations that can be tailored to meet each environment and allows practices to use as much or as little as needed. The report outlines SRH delivery models and provides a comprehensive framework to assist with the planning and the delivery of services. It provides an overview of the scope of practice, which enables organisations to optimise their team's skills and resources. The models are also explored through practical strategies to enhance operations, including MBS opportunities, task sharing, and scheduling examples. The report also highlights wraparound supports by exploring telehealth and outreach models, avenues to assist with financial burden of training, and ways to build workforce capacity within the area. Thanks, Emery. So diving right in, firstly, we demonstrate a tool that can assist with the planning of each phase to structure an SRH model. So as you can see, we have broken it down into 4 pillars with considerations that will provide valuable insights into the practice environment, allowing to shape a model to best suit the needs of the organisation. So under the population pillar, investigating demographics will determine how to tailor your service provision. It will understand the patient demand and offer insights into potential revenue streams. So for instance, if there is a higher number of healthcare card holders within your area, the bulk billing ratio could exceed fees, so potentially reducing the overall income and impacting budgets. As we're looking into framing a model, determining if it is an integrated or a standalone structure in the early establishment phase can assist with financial planning and resource allocations. Lastly, assessing the workforce can identify existing skill sets to expand scope of practice or if recruiting is required. Thanks, Emery. So we know that there are many types of models available in the SRH sector. However, with the financial sustainability in mind and with a community health lens, the report offers insights into 2 key models, a general practitioner-led model and a nurse practitioner-led model. Depending on the availability of the workforce in the area, there may not be an option to choose which model to embed. However, the comparisons will assist you with what you can leverage within the system. So, for example, a GP model can leverage the MBS with greater access to SRH item numbers and an opportunity to co-bill if services are provided. Additionally, if the practice is accredited, it can qualify for other government financial incentives that help cover additional expenses. An NP-led model can offer a holistic self-sustaining approach to SRH care. NPs can bulk bill through MBS, however, bearing in mind there is still no access to the SRH-specific item numbers that GPs have access to. So this table shows the overarching comparisons between the two models. However, the report does go into more detail of each. Next slide, please. Great. So here we offer a snapshot of the scope of practice for a GP, NP, and specialised SRH registered nurse and enrolled nurses. We did choose to focus on these professions as they were the most common in an SRH general practice setting. Recently, maximising scope of practice has been a key discussion across the primary healthcare sector, including the Australian government currently undergoing a scope of practice review. So with this in mind, we thought to include a table to offer a quick guide for practices so they can optimise their workforce. So for example, maximising a scope of practice for SRH RNs or ENs can improve task sharing responsibilities, which then frees up the GP or NP to dedicate their time to manage the more complex patients and offer a balanced workload. RNs and ENs with relevant training have a wide scope of practice, offering advice, assessment, and provide support to a GP or NP. It's important to note that RNs and ENs do not have access to bulk bill patients through MBS. Strategically scheduling nurse appointments to include a GP is important for financial viability, which we allude to a little bit later. Also, maximising non-clinical staff can alleviate the pressures for clinical team. So RACGP standards outline the responsibilities that can be shared with non-clinical team members. For example, even checking the daily temperatures of the vaccine fridges is something that the reception team can do, and this can allow nurses to then focus on clinical tasks that are required. Next slide, thank you. Great. So next we provide a snapshot of the practical tools that can support the process efficiencies and enhance sustainability. The report details a few areas to consider, which you can see some examples on the slide. So introducing an IUD clinic can support scheduling processes with reception and the setup for clinical staff. Also offering online bookings for appointments can enhance patient accessibility for SRH consultations. Practices should register with 1-800-MY-OPTIONS, of course, and include as much information as possible on their website. Streamlining referral pathways and promoting services with local practitioners can increase awareness in the region. Additionally, reception training on SRH services is beneficial to support the comprehensive care offered to patients. So, for example, reception knowing the critical time pressures for early medical abortions or having a good understanding of the SRH MBS billables can streamline processes within the clinic. Thanks, Emery. Great. On this slide, we discuss an example of optimising infrastructure to ensure the practices are accessing all financial opportunities where possible. So we shared this information at a recent Department of Health Hub Forum late last year, with some of the practices making the step to invest in a point-of-care ultrasound for early medical abortion services. Investing in a point-of-care ultrasound can have enormous benefits for patient time and costs. Also, it can reduce the need to refer a patient to a radiology, which in rural areas can be few and far between. By optimising your point-of-care ultrasound, it can be beneficial to get the machine accredited. Although this can be a timely process, it does allow access to MBS billables and the opportunity to co-bill with other SRH MBS item numbers for GPs if you do provide those services. Thanks, Emery. Great. So next I would like to highlight a really exciting piece of work, and to be honest, it's my favourite. So on page 17 of the report, we have developed in collaboration with GPs is a quick guide to SRH MBS billables that practitioners can have handy in clinic. So here is a snapshot. You probably can't see it on the screen, but this is what it looks like, and the considerations and co-billing opportunities that are relevant for each MBS item number. So for example, your routine antenatal attendance 16500 has no time limit, no limit of number of uses, or no limit to the gestational limit. I think obviously GPs having a number of MBS item numbers, it's so hard to remember them all. So we're hoping that this is that quick guide that they could refer to. And as we've just heard in federal announcements last week, the MBS is an ever-evolving landscape, and rules and item numbers will change. So CERSH will develop a standalone MBS guide that's routinely updated as changes are made. Dr. Karishma will talk to the MBS guide shortly with a GP lens. Thanks, Emery. So as part of our model, we highlight wraparound supports that can strengthen a GP or an MP-led service. Since the onset of COVID, telehealth has grown in popularity to provide services, especially to our rural and regional communities. What has supported this space is the permanency of SRH telehealth item numbers for GPs. We really advocate to continue to use these item numbers when applicable to ensure that they remain permanent. In the report, you'll find details along with other factors to consider, which will support the implementation of a telehealth clinic. And just using as an example, a remote GP or NP telehealth clinic where the provider can connect remotely via video or phone. And this could be a really good solution if an SRH provider takes leave and is unable to be backfilled within their position. So this can often happen in our rural and regional practices. Another support is a SRH outreach clinic, which can be beneficial to reach the smaller communities that may otherwise not have access to face-to-face SRH services. As outreach clinics can be costly, we thought would highlight a few considerations to consider. So such as completing a community needs assessment to address the specific concerns, deliver a demand-driven service, so offer a stepped approach introducing the clinic, collaboration with local providers, including practitioners, pharmacies, and pathologies, and work out the logistical details of your patient results, equipment and supplies, and clinical facilities. In addition to these wraparound supports, the report highlights the GP registrar pathway as a valuable opportunity for building the local workforce. If a practice has an experienced provider and can offer clinical supervision, hosting a registrar can help expand SRH services. Scholarships and grants offer a valuable opportunity to cover training costs for the provider or practice, and we have outlined a few that are available within the report as well. Thanks, Emery. Great. So the report may not have all the answers. However, CERSH are available to work with practices and together build practical solutions to challenges that we may face. The report is available on the CERSH website this week, and there are also hard copies available if you like things printed. I know that I do. And as mentioned, an MBS guide will be regularly updated as changes occur and available on our CERSH website as well. Okay, enough of me talking. I would like to introduce Joanne Zamproni, who is the business manager of Gateway Health, including overseeing the funded Sexual and Reproductive Health Hub, Clinic 35 in Wodonga and Wangaratta. Joanne will discuss the challenges and highlights of Clinic 35, offer a practice manager's perspective of the opportunities with the Working Towards Sustainability report. Thanks, Joanne.
Thanks, Carly. Good morning, everyone. So Clinic 35 in Wodonga and Wangaratta. So next slide, please. Gateway Health acknowledges the traditional custodians of this land on which we stand and pay our respect to the elders past, present and future, for they hold the memories, the traditions and culture of all Aboriginal and Torres Strait Islander peoples. Next slide, please. So this is a Clinic 35 overview. So Clinic 35 has a couple of funding buckets. So we'll go next slide and we'll just go through those. So Clinic 35 was established in 2010 in Wodonga, and 2015 in Wangaratta. It was identified that there were gaps in service delivery of sexual health services within our area, and we put in for the funding and were successful. So it started off initially, we started with the STI BBV grant through the Victorian Department of Health, and then put in for funding in 2018 for the Women's Sexual and Reproductive Health hub funding, and we expanded through to Wangaratta in 2022. Our clinic is a nurse-led integrated service model with GP and specialist support. Next slide, thanks. So the key services that we provide as other hubs and BBV STI hubs is contraception choices, pregnancy options. One of the biggest pieces of work we achieved earlier on in our funding was to develop and implement a surgical termination of pregnancy pathway with Albury-Wodonga Health. We didn't have one. There was a practitioner in Albury who was providing the surgical termination of pregnancies and unfortunately couldn't practice any longer. So that was a big piece of work that Gateway Health and our hub worked with. So we're pretty proud of that. Health promotion, and we are also an integrated service with the BBV STI funding that we get, which gives us a lot more opportunity to grow both the hub funding and the BBV STI. Next slide, please. So challenges in establishing a sustainable hub. That's ongoing. I think every day in the times that we're in at the moment, we have consumables are going up, GPs are wanting more money, reception wages go up, nurses go up. So I think sustainability and retaining workforce it's a really big challenge, and it is daily or weekly that we actually look at it and we're wondering, how do we keep this going, and how do we keep moving forward with an affordable model and retain the staff, the skilled staff that we have. So as Carly mentioned earlier, optimising the MBS billing opportunities. So we do use a GP to support the clinic so that we can use those billing opportunities, and with that then it gives us more scope and room within the hub model to be able to explore and expand on ideas and things that we'd like to do to promote women's health to the outlying areas of Albury-Wodonga and Wangaratta. So it enhances collaboration with GPs and external stakeholders, and it ensures our financial viability through effective cost recovery. So operational barriers, GP shortages. So we unfortunately had a GP that supported the hub go on leave and had to strategically think of how were we going to run a service when we needed prescribing, we needed diagnostics written, and we didn't have a GP on the ground for a period of weeks due to a leave. So we reached out to a registrar who had done his placement with us and moved back to Metro, and he happily decided to join us every Wednesday afternoon to see our patients that required scripts, diagnostics written up, and with the ability of e-scripts now, that just worked beautifully, and it helped us with that shortage and try to be innovative and creative on how we can still provide a service when we do have shortages in remote and regional areas. Fixed term funding, I guess the uncertainty in long-term sustainability. So what funding down the track's going to be. So if we lost funding, can we still provide the service? So how can we do that and be able to provide the service to women and vulnerable populations? Clinical governance, making sure that we're up to date with our accreditation, policies, procedures, and that we have everything in place so that if someone was to leave and someone came in, we have that all ready to go and updated regularly. Cost of consumables, as I said, they seem to be escalating post-COVID. Staff and administration costs are also going up. So how do we retain admin, management, agency service fees in the funding that we receive? That is, it's a big barrier. So like, do we do more around, like with the GP billing, it gives us a little bit more room to move, but long term, is that sustainable? Time will tell, I guess. Reporting, we do have a few barriers with reporting. We've got 3 systems that we work from here at Gateway Health. We use Track Care, we use Best Practice, and we also follow up with some Excel to make sure that we are capturing information that we would like to report back on. It would be great to have one reporting program to be able to actually capture the great work that is done. So because we do use 3 at the end of our reporting quarters, we're always sort of trying to scramble and make sure that we're working with our SIMS team here at Gateway and making sure that we've got the right data. And sometimes we do check that off against an Excel sheet and go back to a manual sheet. Next slide, please. So the report that Carly, Anne-Marie and Professor Jane did, it's a fantastic report. I wish I had that when we first started because it's got some fantastic little ideas in there. It would have taken a lot of months and years of trying to work out and scope out how the practice is. So it does take significant time and it's extensive learning, and we're always learning, so it's great. So service deliveries, what works for your hub? Is it GPs, nurse practitioners, nurse-led models? Financials, like the billing opportunities, the MBS schedule that Carly was just talking about. Handy to have laminate put in GP's room so that it's a go-to. They don't have to fumble, or even if reception are aware of the billing fees. Telehealth, great resource, makes the world a little bit smaller, and people who need to access the Women's Hub for women's choices, and they have the ability to do that while they're still at work, not having to travel the distances, because like we have people that travel for like long distances to get here. Capturing incentives like our WIPs, which is our workforce incentive payments, any grant and scholarships that we can to sort of consolidate the work that's done within the team, but also give us the opportunity to grow. Governance, as I said earlier, the accreditation policies and procedures, and expanding service delivery to outreach. So we're currently scoping that at the moment with a van in one of our little towns in Myrtleford. So they've got a bus that's fully decked out as a clinical bus that we can actually hire for a small fee. And looking at going to areas like Corryong where there's no GPs, and seeing how we go. So it's something that we are scoping at the moment. So hopefully we can get that to happen in the next few months. And training and education, I think that's always on the agenda for GPs, nurses, management and reception. So the document definitely covers all that beautifully. So service impact and future growth. So this is where we're at. So just a little snapshot of what we do. So 75% of clients receive care from our nurses first, demonstrating an efficient workforce model. 36% increase in clients. We saw a 36% increase in clients in 2023-2024, showing growing community reliance on our service. So we're getting out there more and people are knowing who we are. 12.5% of clients would not have sought care if Clinic 35 didn't exist. So we've captured that data in a survey because we do patient satisfaction surveys, and that's what, and actually I think that's actually increased. We're doing one at the moment. And we have active partnerships with Aboriginal Health Services and LGBTQIA plus support groups and multicultural communities within our areas, both Wangaratta and Wodonga. Next slide, please. So strategic focus areas moving forward is strengthening integration with GPs and medical practices in our areas to enhance service sustainability. Expanding regional health promotion initiatives. So we try to go out to as many things as we can. where I'm actually going to one with one of the receptionists because the nurses are all busy, so that we are out there and we're putting ourselves out there. Advocating for continued government and stakeholder funding, and enhancing digital health solutions to increase accessibility, especially to the areas in our outlying areas that don't have GPs or healthcare services. So embedding Clinic 35 into the medical practice is essential for long-term sustainability. So I think we're a brand now. People know who we are and where we are, but we can always do better, and we're doing our best. Collaboration between the nurses, GPs, administration and community stakeholders is a success, and it's proving that, you know, the more people that know about us, the better it is. And support for advocacy funding is crucial to continue providing high quality, accessible sexual and reproductive health care. And I'd just like to take the opportunity to congratulate you, Carly, Anne-Marie and Professor Jane. The document's amazing, and I think everybody will really appreciate the work that's gone into that. Thank you.
Oh, thank you so much, Joanne. Clinic 35 has done an outstanding job establishing the SRH Hub and thinking creatively to tackle the challenges that you face. So we hope this report serves as a time saver, as Joanne said, for those future hubs in those rural and regional areas. Great. So I would like to now introduce Dr. Karishma Kaur, who is a SRH specialised GP and the clinical lead of the funded SRH Hub at Bendigo Community Health Services. Dr. Karishma will highlight the Hub's journey and offer a GP's perspective with how rural and regional GPs can incorporate the resources into their practice. Thanks so much, Karishma.
Thank you, Carly. Hello, everyone. As Carly's mentioned, I'm GP at the Sexual Health Hub at Community Health Services in Bendigo, and I'm also the clinical lead there. I would give a big shout out to Carly, Anne-Marie and Jane for the report. It's amazing, and thanks for giving me the opportunity to work with you guys. I'll just move to the next slide. Thank you. Well, I would like to say that hubs traditionally have had a very passionate workforce, and historically the SRH hub has been a nurse-led model for us at BCHS. So we at BCHS have a long history. Even before the hub was established, there were nurses and doctors that were working very passionately to support the sexual health needs of the community here. When I joined Community Health in 2019 as a GP registrar, I was very fascinated about the fact that there was a sexual health services. So the next year I took up as extended skills at Community Health Services at the Sexual Health Hub. At that time, we had one GP who was the supervisor working 1.5 days a week. And other than that, I was the one who was working here. Unfortunately, COVID hit, but there was a lot of learning from that too. Once we came out of COVID, I had fellowed, and they could retain me, so that's why everyone highlighting, especially Carly highlighting the fact that having registrars makes a big difference. It does, because it introduces your services to the new generation, and once they're happy to take it over, then you can actually build big things out of it. However, now to work towards sustainability, we have done a lot of things over the last few years. Working with Carly has also made me realize the importance of a GP-led model that we do here. It has increased our scope of practice to continue providing a holistic and comprehensive approach to our community here. And I would really like the new hubs or smaller hubs to be able to look into this, because this is all the hard work that lots of hubs have been putting over the years, and this can help you in establishing or putting up services in place without reinventing the wheel. We'll move to the next slide, please. Thank you. Well, I would like to acknowledge that I work with an amazing team, and whether GP, nurse practitioner, everyone puts an amazing effort to get on where we are today. We do have 6 GPs and a GP registrar, a total of 2.6 FTE at the moment, and I would say we're just lucky. And as Joe has highlighted as well, it is hard to sometimes retain. We don't know what the future looks like, but we are just lucky at the moment to be able to have that many GPs on board who are happy to support us at Community Health in Bendigo. We also have 2 nurse practitioners, 1 male and 1 female, and we have 3 RNs who do an amazing job in running a lot of different programs that we do here now. The nurse practitioners do see the patients independently. The RNs are supported in their consults by the GPs. So GPs see their own list of patients and the nurses see their own list of patients. But with every consult for a nurse, for an RN, we go in and bill the patient accordingly. It depends on the time we at the end up spending with the patient. This does not take the nursing time into account, so but it does make us service a bit more sustainable. We'll go to the next one, please. Now, these are some of the services that Community Health provides. I'm sure I've missed a few. A few highlights of our clinic at the moment is the endometriosis clinic that we run. We are also supported to provide the STI check and treatments. We are in the process of coming up with a gender diverse clinic. We have 2 of our GPs who provide care at the moment, but it will become more structured as a half-a-day clinic every fortnight that we would be providing for gender diverse people. We also do a lot of pregnancy counselling, medical abortions, and we are also running a men's health clinic. Just to highlight a few things, I would say that we have seen in the last year, January to December 2024, 2,452 people in the clinic, out of which only 874 had concession card. So it does highlight the fact that, we cannot sustain alone on bulk billing practices. We don't get incentives. So, which I'll talk about a bit later as well. For our sustainability at BCHS, we have moved on to a mixed billing practice. We have done approximately 217 medical abortions last year. We do not have a data to say how many we referred, but we have done around 300 unplanned pregnancy counselings. We have inserted 347 IUDs and 146 implanons. So our IUD clinic runs on every Thursday. We are 4 clinicians who are providing the service. We most of our IUDs have 3 consults. The first one is a pre-IUD consult, which is run by the nurses. The third one is also run by the nurses. So it's saving GP time, and GP can invest the time doing things which they need to be working on or providing care for in the community, which can be more pressed on. We'll move to the next one. Now, challenges. Everyone's talked about challenges. I'm going to say nothing different, but workforce shortages is real. As I said, we're just lucky at the moment, but we don't know how long we'll be able to retain. So having practices which are supervising practices, having GPs who could supervise can also help you training new staff. The other thing I feel, which is very common in sexual health hubs, is professional isolation and burnouts. Because we could be working in a space with very high need people. We at Community Health see a lot of clients that have already probably seen a few clinicians before they come to us, and they're demanding a very specialized advice from us, which can be really exhausting for a lot of us. We also have limited workforce to support us. We might not have too many specialists to look up to. We're lucky in Bendigo, but I'm sure as we move more regional and rural, there are less and less people that can support us support the GPs through that kind of a thing. Now, we all GPs trained to do things like IUDs, implanons, but what I felt, even people who've done the training, they're unable to retain that training because there's not much support. Sometimes you do not know if you're doing the right thing. So what we are working towards building at Community Health is also to be able to support those smaller services. So we are a training practice for IUDs, and the way we do it is we do train them in 1.5 day session, but at the same time provide a bit of an ongoing support, which helps you build up confidence. And then once you train your GPs could be training your nurses and nurse practitioners locally as well. Now, financial sustainability, sorry, I'm not going to go much in detail of, but we know that there's high operational cost, and we are dependent still on a lot of government subsidies. But to become sustainable, us at Community Health had to move towards a mixed billing practice. We still bulk billing concession card holders and anyone under the age of 18. Bearing in mind that we do understand that we're working with a very, varied group of people, and it is left to the doctor's discretion if they want to bulk bill or not. I would say still here we would be bulk billing most of our consults a day. Yes, please. Next one. Now, just for a few things, these are also kind of a bit of a solution to the challenges that we faced. So to maximize the scope of practice, as Carly has already mentioned, the report is a quick guide for practices to build up their scope, to build up, train their RNs, ENs, and maximize the scope of practice. The RNs, ENs are an amazing resource. Once we've trained them, there's a lot that they can assist the doctors with. And that helps us with scheduling efficiencies. The nurse can always task share. But like us, we do MTOPs, and our first MTOP or unplanned counselling is a number of times is done by nurses, and that assists our doctors because we don't have to spend 36 item number 36 or 40 minutes to with the patient to talk about that. We could just go in, talk to the patient, spend around 6 to 10 minutes, and then bill accordingly. But the patient is more prepared on how to go through the procedures. Similarly to IUDs, we do have a great feedback that we get from patients here that they do tend to see the nurse first, who prepares them for the consult, and then when they come and see the doctors here, they're more prepared. So it's financially sustainable because you spend less time with the patient. You can bill them accordingly to that. At the same time, you could be doing effectively your work as well. And then we also talk about balancing the cost and accessibility in the same way as, do what suits you the best in your regional area. And if you feel that you've got more bulk billing clients coming in, then you could probably avoid going into, or concession card holders coming in, then you could avoid the fact of going into mixed billing. But unfortunately, in today's time, some of us have to do it, and that's absolutely fine. Since we've started in November, we've had a lot of people say that they are happy to pay because they're getting a quality of service as well. Thank you. So I would just like to take a bit of an opportunity to talk about some of the things which could be, about co-billing. The GPs, the nursing staff, the SRH Hub could use this guide. I think Carly has highlighted it wonderfully. It looks amazing. She's talked about how it gives you a snapshot of what you could do with telehealth services. We need to be billing that more. As GPs, we're always concerned and scared of doing co-billing, but I can tell you that it can be safely done. Simple things like billing pregnancy tests, which I'm guilty of always missing out, and then also being aware of item numbers like 4001 or 16500, which can 4001, which can be co-billed with other items as well. So use the snapshot, print it out, give it to your clinic. It'll just help you do all those stuff easier. Great. That's all from me. Thank you. I think I went over time. So sorry.
Fantastic. Thank you so much, Dr. Karishma. Such valuable insights from a regional GP's perspective and how this can support the efficiencies of workflows to improve patient-centered care. So we greatly appreciate you spending the time to talk to everyone. So as we come to the end of the launch, I would like to finish off by highlighting the strategies and work CERSH are exploring for the future, and that will continue to build and support the SRH workforce in rural and regional Victoria. So on a needs basis, CERSH will continue to work alongside practices to help with identifying areas to enhance SRH service delivery. We will be here as a resource to also assist in the implementation of those practical solutions as well. So in addition, based on conversations across the regions, we will work to establish a forum for SRH business managers, as there was a desire for these professionals to come together, share and provide solutions to the ever-changing SRH sector. There will be great opportunity to discuss operationally what's the most efficient and cost-effective way of doing things instead of just reinventing the wheel, as we've discussed. One of the next stages of the Rural Services Development Project is to create a mentorship program for aspiring rural and regional professionals, partnering with leading SRH providers to implement a structured mentorship program will provide opportunities for the aspiring workforce to build confidence closer to home, supported by some of the most experienced professionals in our region. A key and fundamental component of the mentorship program will be wrapping supports around our regional mentors and ensuring avenues of compensation for their expertise. So we truly want to establish avenues that can be sustainable long term. That's our aim. Thank you so much all. I'll pass it quickly back to Anne-Marie for any questions that may have come up.
Thank you very much. That was excellent timing by everybody, might I add. We did have a few questions around accessing the report. We have hoped that it will be live on our website on completion of this webinar. If it doesn't, that's an IT thing, but it definitely will be available tomorrow. So please jump on and check now. It should be there. If not, it's just a delay in the upload and it'll be there tomorrow for sure. We do have access to hard copies. I know someone requested that. All you've got to do is simply reach out to the CERSH team and we'll be able to provide you a hard copy of the report. Now, I will provide, seeing as we've got a couple of minutes, if anyone did have any other questions, I'd encourage you to pop them into the chat. Jill, if you're still there with us, we do have one around the availability of scholarships and funding for those working in community health that was mentioned. Where might people find the information regarding those grants?
Thank you. If they want to contact, I'm happy for them to have my email. They can contact me and I'll send it through to the team. I don't know whether, I think the applications have closed for this year, but we can certainly look at if there were any that weren't taken up or can't be taken up and whether there's any available. Thanks.
Thank you so much. If anyone does have any additional questions that they haven't, they might want to have a look at post the report and pop to the team. I would encourage you. The report is quite large and today was a lot of information. Hopefully people got a lot out of it, but please do reach out to the team. We're more than happy to answer any questions and unput the report in more detail. So thank you very much. I won't take up any more of people's time. Thank you to our fantastic speakers today. We really appreciate your support and we really are looking forward to the next year and all the things that are happening in the fantastic women's health space. So thank you very much, everyone. Take care.